And now I will start recording for uploading the stuff on a video. But I will share a link to the presentation files so you can see it without looking at me. That's applause. But now it's going to become more interesting. 1 minute to go. The birds are singing outside my house. Last night there was a fire like 6 miles from here. And all the ashes are all over town. I think there were no human losses. It's always a concern. Now, different day. Let's live today. And I think the ones of you who attended the first time we spoke about pelvic problems can remember my focusing on pediatric pelvis masses. We can see pelvic masses even inside the uterus, inside the womb. When the baby is inside, we can spot some ovarian cysts. Some of those are malignancies. Some of those are functional. When we find free floating echoes inside a cyst, it could be a dermoid cyst, but it could be a dysgerminoma or a pediatric gynecological cancer. This is an example of a baby who we found a cyst with some echoes when the baby was inside the mommy's womb. And then when they brought her to us and she was 7 months old, we find the same thing. Waiting to see what happens next. You know, sometimes I find malformations or problems in fetuses, in babies inside the womb. And some colleagues say, oh, there's nothing. She's peeing and shitting and eating and screaming properly. No problem. This is a problem. And can become that. A big, complex mass on the pelvis of a preteen, younger, with low resistance blood vessels. Inside the mass. And I would never forget Leah and her mom. They underwent a oophorectomy for ovarian cyst, which happened to be ovarian cancer or germ cells cancer. She was 18. She had the surgery when she was like 16 and a half. And traveled all over America looking for miracles. And then I follow up the evolution of a complex mass with a diagnosis of germ cell tumor with low speed flow on septations. This is September the 1st. On the extended view, you can do that on your brain. You don't have if you don't have the machine which allows you to take extended views, you can do it on your brain. This was February 2018. The uterus in a complex thing with a lot of free fluid. Everything frozen inside. February 2018. 2 months after that, we found liver metastasis. Subsplenic metastasis, free fluid. So when you first see something, make your best. You can make the difference. If you suggest malignancy, somebody will must or ought to, in my British accent, do something else than a simple oophorectomy. And we don't need a fancy machine. This is a really old image of an ovarian cancer. A septated annexal mass corresponding to a complex ovary in a perimenopausal woman. This is not normal. It's not big, but it's not normal. If you're 45 years old, you will not have ovulation from 3 follicles. This is not normal. This is not functional. Think on the context. This is not normal. But sometimes we have to say, I don't have an idea of what's going on here. But something's wrong. Something's not normal. Here we see the uterus, something complex and attached to the uterus. Believe me, when we press here, everything moved like a single body. The opposite side ovary, and on the left adnexa, some ovarian echoes and a complex mass communicated with the ovarian blood vessels, which we will extensively investigate and see from each angle and try to fill up the expectancy of the referral for us to give them a clue, some light of what's happening. The mass is attached to the uterus without blood vessels continuity. This is blood vessels on the mass. These are blood vessels on the uterus, no communication in between. But communication to the left ovaric artery. So this is some tumor on the left ovary. The kind of thing that makes us say, I don't know. Probably cancer, probably. Another ovarian cystic complex mass. Now on the right side, attached to the ovary. This is the ovary, this is the mass. When you see lines like that, this can be the fallopian tube twisted. Usually is the fallopian tube twisted. Very frequently after a tubal ligation. But this has blood vessels on the septum. This is not endometriosis. This is ovaric with blood vessel on the septum. This is a tumor, complex, cystic. Cystic does not mean benign, not necessarily. It could be a cystadenocarcinoma. More of the same. And every one of us has the right to have two defects. Ugly go with bad English, that's me. Put yourself your label. This is fibroid, bullous, ovarian mass. Fibroid, complex, abnormal ovary. Low resistant blood flow. Connected to the right ovaric artery. Meaning left. Left abnormal ovary. Abnormal things after hysterectomy. Sometimes we leave alone the ovary because we don't want the lady to become suddenly menopausal. But there's an abnormality, a cyst, or remnant tube twisted. Who knows until we do a laparoscopy. But something is not right. Sometimes we find complex pelvises and masses. This is the right ovary, this is the left ovary, there's a bunch of free fluid. Left ovary, but something is wrong. She's not pregnant. This is not an ectopic pregnancy. It's not impossible to have an ectopic pregnancy without a positive pregnancy test, but not very common. With the complex mass, which apparently is the tube and it can be due to chronic salpingitis. This is the ovaric artery. And cystic-like things that are not gynecological, but sometimes are found by somebody else and refer as a cyst. Here we can see a cystic thing behind the bladder. This is one of the iliac blood vessels. This is the bladder, and this is the cyst. Notice that. If I press against the gallbladder, I have flow. Communication between the urinary bladder, and the cyst-like thing. This is a bladder diverticular disease, an abnormality of the urinary bladder. Not gynecological, urinary tract. See that? Let's take a look at it. Nice. You need to be active. Sometimes you need to press a little bit. More about the great mimicker, endometriosis. The uterus, a mass behind. Oh yes, the uterus is something by the side of the uterus and behind. That's clearly abnormal. We see a bright spot where we don't see clear boundaries. This is not a dermoid cyst, not a pretty site cyst, but an ugly, ill-defined, complex mass inside the pelvis, most probably endometriosis. Complex. All the gray scale is inside here. Some free fluid, you can see the free fluid. In the corner. The little angles. See those? That's fluid. Between the intestine and the peritoneal wall and the mass. This is free fluid. It has no blood vessels, no inside, no vascular changes inside, but surrounding it. It's a complex mass, not a tumor, but endometriosis. Now, what when we find a thick endometrium? Thickening of the endometrium can be due to hormonal changes, the endometrial cycle, depending on the menstrual ovarian cycle, hyperplasia, polyps, submucous fibroids, endometrial cancer. There is thick endometrium, like 11, 12 millimeters wide. Thicker endometrium, probably hormonal. See the colors. This is probably a secretory phase endometrium. And even thicker endometrium with a normal sized uterus, 8 centimeters long. Another variation of thick endometrium, normal sized uterus, a functioning ovary behind with the dominant follicle or whatever this is. This looks like functional. It's not a cyst, no echoes inside, mildly echoing. And a little bit more enlarged uterus, 9 centimeters depth, wide endometrium. This is not normal. This usually belongs to hyperplasia. Most referrals on my area think first fibroids. They tend to ignore endometrial things and prefer fibroids as a diagnosis of abnormal uterine bleeding. But sometimes it's the endometrium, and the management is different. And the impact of what we do is different. Fibroids don't become cancer. This can be the beginning of an endometrial cancer. More enlarged uterus, thick endometrium, thin line inside, really abnormal endometrium, 2 centimeters wide in the anteroposterior axis. Normal sized uterus. This uterus is underestimated. This is just the body of the uterus. This is the cervix. And if we don't pay enough attention, we can miss this. The endometrium doesn't start here, from here to there, but from here to there. Look at the screen. Muscle, endometrium, all the width between this and this mark is endometrial thickening. Complex, thick endometrium and enlarged uterus. She needs an endometrial biopsy. More of the really thick endometrium and enlarged uterus. This lady needs an endometrial biopsy or dilation and curettage for both things, solving the problem and having a diagnosis. And most of the instance of these patients, they are referred because abnormal bleeding. If they come from a procedure, sometimes these are leftovers, things that are inside after the dilation and curettage. But this looks like what? Submucous fibroid or polyp? This can be a polyp. And either with a procedure like a sonohystero, which is putting a catheter through the cervix and filling up the cavity with fluid and then having the ultrasound images, or with a hematometra, which is a fluid-filled cavity because there's blood inside, not because we filled it up. We can clearly see a polyp. This is a polyp. May I introduce you, Mr. Polyp, our friends in Ghana? Nice to meet you. Variation of the same tune. Endometrial polyp, the color is more alike, endometrial alike, not myometrial alike. And compared with this, which is a submucous fibroid, the color is more myometrial alike. Not the same thing. Endometrial alike, myometrial alike. Which if we play a little bit with the rendering, we can image like this. This is really nice. I hope my sister watches this. We don't need a fancy machine. We need to be patient, skilled, and pay attention to what we are dealing with, the person and the details, which allows us to be of any help. Helping the other, serving the other is our goal in this life. Nice images of submucous fibroid. This is again a natural hysterosonography. The hematometra with the complex echoes and synechia, intrauterine adherential tissue between one wall and the other, and the submucous mass. Cannot tell if a submucous fibroid or a polyp. It looks like a polyp with the color of the fibroid. So there's exceptions of all rule, and that one I mentioned was not a rule, was just one of a few clues to approach to the diagnosis. Intercavitary complex mass, and the uterus seen from the outside, like a laparoscopical view, but this is a rendering. This is a volume rendering. But we don't need the fancy machine. Sorry, Maria Elena, we don't need that machine. We can do that with the old dinosaur. Submucous mass, myometrial alike, inside the endometrial cavity, and the vaginal examination. Oh yes, we had an endovaginal probe for that machine. And we see a 2 to 3 centimeters wide mass inside the endometrial cavity. And this one with the submucous mass and the complex uterus. What is probably this? An adenomyosis. Complex uterus, like a salty thing, like a snowstorm, plus a rounded shaped submucous mass, which pushes up the endometrium. In a normal sized uterus, very complex uterus with a submucous mass. Doppler color on. Another submucous mass in a patient with abnormal bleeding. This is not normal. This is not normal. Polyp-like, wider, brighter, up on the grayscale. Not myometrial alike, but endometrial alike. Plus a complex adnexal mass. This is, well, this was labeled as ovary, but I think this can be a twisted tube. Anyway, our job is to tell the referral and the patient, this is not normal, something happening. It looks like a twisted tube. Hydrosalpinx, twisted hydrosalpinx. This one, probably a polyp, endometrial alike. This one, who knows? A polyp because of the shape, submucous fibroid because of the color. Either of those, they need a hysteroscopy, passing through the cervix with the fiber optics line and then looking at it and then resolving. But this patient had a prescription of estrogens, and this happened. Slightly bigger mass. This is the same patient a year after, referred by the second time, with no solution of the abnormal bleeding, same submucous mass, but bigger. 1.7 centimeters wide, 6 millimeters wide, more abnormal. Clear, not that clear. Same patient. Some fibroids are small, as I told you, less than 2 centimeters. Some are big, not fancy machine, enough to see. Most fibroids, this is bigger than 4 centimeters, 8 centimeters width. Subserose, they make the people, the uterus to look pumping from the outside. Big fibroid, big bumpy. This was the original shape of the uterus, then all this is extra. Fibroid, endometrium, 2 problems. Hello, 2 problems. Ugly and nasty, 2 problems. Slightly bicornuate uterus with some fibroids. See, the arrows are pointing to the bicornuate shaped endometrial lining. Another finding that we can have collection with an IUD, lowly inserted. And those unusually shaped uterus are a problem whenever we have to do a blind intervention of those, because to perform evacuation of a bicurrent uterus is not always successful. This patient came in with fever, pain, steady bleeding after a DNC. When we find her to have a bicurrent uterus with echoes on one side, complex echoes on one side. This is the endometrium on the clean side, let's call it that, and this is complex echoes in the endometrial cavity on the opposite side. Some patients have late afterbirth bleeding due to retained placentary leftovers. And we see those heterogeneous echoes inside the cavity. This so-called abnormal bleeding after taking emergency pill. This is an emergency. Oh, I'm bleeding. Sorry about that, but this is highly predictable. This is what the pill was intended to do. Decision consequence. Now solve it, doctor. We can have bleeding after miscarriage due to some leftovers inside. We have to evaluate how much in order to decide what's next. They can have bleeding after hysterectomy, especially if it's a obstetric hysterectomy. We see that in abnormal bleeding postpartum problems. Usually the patient is overweighted with preeclampsia, sometimes severe preeclampsia, with some kind of abnormal placentation. Anyway, it's not easy, technically speaking, to take the whole uterus out after birth. So most hysterectomies are subtotal, and they have a really small uterus left, which can bleed. They deserve an explanation of that bleeding. And most of the times they don't know why they're bleeding if they don't have the uterus. Well, you have a little piece of uterus left. This is very interesting, not for the patient. 3 months after delivery, on slightly bicurrent uterus, we find this. No material lining towards the right side uterus horn, and something complex on the left side. And we see this. There are several kinds of trophoblastic disease. And one of those is the placentary insertion site trophoblastic tumor. And another kind of that is the choriocarcinoma. How we differentiate that? Well, by pathology, not by ultrasound, but if we find abnormal echoes located The ovaries are normal, not tecaldutenic cysts. But the uterine arteries think they're still pregnant. This is not usual in a non-pregnant uterus. This is a low resistant blood flow. This uterus think there's a baby inside still because there's hormonal activity inside. This is the right uterine artery, the left uterine artery, both low resistance, not pulsating much with high speed. This is around 170 centimeters per second, meter per second, with high diastolic blood flow. Something's happening, and we have surrounding the region of interest a big crowded of blood flow area with low resistance blood vessels. Yes, this can be choriocarcinoma or trophoblastic placentary site infection tumor, insertion tumor. See this. This is surrounding the area we marked on the first images. Which has its own blood vessel nurturing it. Low resistance thing. So, what to bring home? There are several arguments for asking pelvic ultrasound examination. Abnormal bleeding, abnormal menstruation, pelvic pain, palpable mass. We can touch at something. The causes of pain, usually the most usual cause of getting to the office is irritable bowel that they think is an ovary messing. It's not almost, well, not always the ovary, but take a look at it. You can have surprises. Causes of bleeding, IUD, endometrial bleeding, fibroid, the day after pill, the ismocele, that small collection on the space of the defect of a C-section scar, and a mass which is not a mass or a fibroid. To say is your colon, not your ovaries, you must clearly see both ovaries. Locate the ovaries, be patient, move smooth, and see that the ovaries are not related to the pain. Scan where it hurts, and if it hurts in the intestine, the pain is caused by intestinal cramping or inflammation, not because of the ovaries. Remember, fibroids do not hurt, and not all the bleeding comes from fibroids. Think endometrium. Don't rush. Take your time, be patient. Don't make conclusions before being sure. Take a look at things. Yesterday, I saw a patient with a overriding aorta baby, and I bet it was overriding. And then after that, changed position, and then the aortic root was in line with the septum. I would not dare to call it a miracle. I prefer to call it my mistake, but don't make a report before being completely sure. Remember, ultrasound is your sight. You're looking at things. It's not biased because we actually see it. It's evidence. It's first-hand evidence, visual evidence. Care the person, especially if we have a no problem situation. Care the person. The person has a problem. She thinks she's on trouble. Care the person with, without, and regardless the problem found or not found. Do your best. I try to do my best. Forgive my accent. It's the only one I have. But with whatever machine we have, let's do our best. That's my email address and my website, internet name. And as I told you, it's always a pleasure. Wow, 2 hours. This is a record. Want more? There's more of those. Hey, great looking. Did you enjoy? Thank you, thank you, thank you. As my grandson says.
Thank you, Pedro.
You're so kind. Hey, you look better. Fully recovered.
Yeah.
Keep
I'm
away,
taking it easy.
keep away from mosquitoes.
Yeah. So, Pedro, nice having you. We'll chat later in the day. Okay.
Well,
All right.
at your service, always.
All right. It's a pleasure.
Coffee time. And I will upload all the stuff and share it with the people.
Okay. All right.
Take care.
All right. You too, Pedro. Thanks.
Blessings.